Hello everyone, welcome to Lecture 6. We're going to wrap up our discussion of stroke by reviewing the risk factors and going over how functional recovery occurs following a stroke. As far as risk factors go, they can be either modifiable or non-modifiable. We'll talk about those. And then the recovery, I want to distinguish what happens in the short term versus long term. Your role as physical therapist is going to be in the long-term recovery following stroke. During that about 3-month period when you can expect to see gains in functional recovery. Stroke is very much a cerebrovascular disease, so the risk factors here are going to be anything that affects the integrity of your vascular system. Like pretty much everything we're going to talk about in this class, age is a major risk factor, and so is previous stroke. About 3/4 of all strokes would be first strokes, which leaves the other quarter to be a recurrent stroke. So after having one stroke, you want to minimize your risk factors to ensure that you're not going to get subsequent stroke. We'll talk about the minimization of risk factors in a bit. So if we have a look at this plot, what we're looking at is the risk of any stroke with age, race, and sex. As we move from left to right, we're looking at older groups, and we can see that the risk of stroke, of course, increases. It's going to double about every decade or so after 55. Race does impact stroke risk, depending on age at least. White men, at least younger white men, have about 50% lower chance of stroke than Latin or black men. Now, as we can see in this plot, that reduced risk isn't always present. In the oldest groups here, 75 to 84 and 85 plus, we can see that white men in the blue bars have greater risk than black men. So this isn't always the case. The racial differences are somewhat tricky. So are the sex differences too. Normalized to age, men have an increased risk of stroke compared to women, but women have this issue of living longer, which gives them an overall higher risk for stroke over their lifespan. Because they live longer and age is a major risk factor for stroke, as women outlive men, their relative risk of stroke increases. So in this plot, we're looking at the cumulative frequency of strokes across time. You can see for men in the black line here, it kind of levels out later in life, and that's because there are far fewer men who live into these very old age groups. Whereas with women, the slope is a little gentler early on, but it continues upward, so that in the oldest age groups, which predominantly include women, here's where you see the greatest risk of stroke. So it's a little tricky. Men tend to have strokes a little younger, but women outlive men. So the overall instance of stroke can be higher. Of course, your age and race and sex are what we consider non-modifiable risk factors. So are your genetics. Before your eyes glaze over with all the letters and numbers here, all of the mutations that are risk factors for stroke converge at vascular smooth muscle cells. So it's a fairly straightforward story. Mutations that decrease the number or contractility of vascular smooth muscle cells increase the risk of stroke. A couple of mutations mentioned in the book occur in transcription factors. The two named here would be FOXC1 and PITX2. Both of these regulate the expression of contractile proteins, like actin, for example. So when we look at actin-positive smooth muscle cells in panel F here, we can see that FOXC1 mutants have a decreased abundance of vascular smooth muscle cells, positive for actin. Without these contractile proteins, the vasculature becomes less flexible. As such, it becomes more prone to stroke. In the bottom panel, here we can actually see a large and small blood vessel stained for smooth muscle actin. That's what the green is showing us. Blue is just showing us nuclei. That's just to show us where cells are, and green is showing us what we care about, smooth muscle actin. WT just means wild type. In panel I, we can see fairly uniform actin staining in these large and small blood vessels. On the right, the PIT-X2 knockouts. Here we can see the staining of actin is abnormal. We don't have actin distributed throughout the entire vascular wall, and as a result, this blood vessel is going to have reduced contractile properties and be prone to hemorrhage. There are other mutations that are going to affect contractile protein expression. This would be in a histone deacetylase or a cyclin-dependent kinase. You don't really need to know these specifics, but what you should appreciate is that mutations that impair your vascular function increase the risk of stroke. This could be in smooth muscle cells, or it could be in the blood cells themselves. So sickle cell disease increases the risk of stroke because of the increased aggregation of sickle cell erythrocytes compared to normal erythrocytes. Because they're aggregation prone, there's a higher risk of occluding vasculature and thus causing stroke. We should think of stroke as a vascular disease of the cerebrum. So we call it a cerebrovascular disease. And it's very much related to cardiovascular health. In this plot, we can see the proportion of patients that have different levels of hypertension or not. The majority of stroke patients have at least stage 1 hypertension here. So the minority of patients don't have hypertension. In other words, hypertension is a significant risk factor for stroke. So is cardiac disease. Whether it be a valve dysfunction or non-valvular dysfunction, anything that impedes clearance of blood from the heart can lead to the formation of clots. And when the clot does finally make its way out of the heart, of course, that embolus runs the risk of occluding cerebral vasculature, since the brain is one of the first stops downstream of the heart. Consistent with this, in the month following myocardial infarction, stroke risk is elevated. You have about a 30% chance of stroke. So in that case, you want to have blood thinners in that month following myocardial infarction. Of course, as we've already mentioned, atherosclerosis is a major risk factor for ischemic stroke because it increases the likelihood of embolism by narrowing vasculature diameter. Aside from cardiovascular function, there are other systemic risk factors like leukemia. In this case, you're going to have an increase in white blood cell abundance. This essentially thickens the blood and can lead to an overloading and blockage of cerebral vasculature, causing ischemic infarction. Diabetes is another risk factor, not only because it increases the risk of cardiovascular disease, but insulin also has important functions in regulating the contractility of our vasculature. In this table, we can see the relative risk of stroke in diabetic patients versus non-diabetic age-matched controls. And across all studies, we can see an elevated risk, certainly for ischemic stroke. The hemorrhagic stroke in the middle column here isn't always elevated. And the risk of all strokes, since they're primarily ischemic stroke, is of course elevated in diabetic patients. This plot is showing us the effects of insulin on blood vessel relaxation. On the x-axis, we're looking at the dose of insulin The left here is showing us a nanomolar dose, and on the right we can see micromolar doses. So we're increasing concentration from left to right. The y-axis is showing us relaxation from 0 to 100%. So the lower we go, the greater the relaxation. So it's maybe a bit opposite of what you would expect. The open circles are showing us just regular old normal diet rats. They've acutely isolated blood vessels and then treated them with insulin. With a normal diet, we can see relaxation in a dose-dependent manner. The black circles here are showing us the relaxation of vasculature from rats fed a high-fat diet. So diet can have an impact on stroke risk as well by interfering with insulin sensitivity. And that brings me to the next point, which is, of course, dietary risk factors. It's not really about the total amount of fat, rather it's about the type of fat. So we have low or high density lipoproteins, bad or good cholesterol, if you will. The cartoon on top here is showing us the mechanism by which LDLs act as bad cholesterol. So low density lipoprotein is prone to oxidation. When it gets oxidized, it's going to trigger an inflammatory response. It's going to get taken up by macrophages. They're going to form what we call foam cells, and this is, of course, going to cause a buildup within the vasculature itself. Prolonged inflammation can lead to degeneration of the vasculature. For example, fibrinoid necrosis can occur. So low-density lipoproteins are particularly problematic because of their ability to be oxidized and trigger an inflammatory response. This does not appear to be the case with high-density lipoprotein, which is why we consider it good cholesterol. In the bottom here, we're looking at two plots of the same data, but shown in two different ways. If we start on the left, in both cases, the y-axis is showing you essentially the risk of stroke, one being normal risk. Anything above that would be elevated risk. The x-axis on the left is showing us the consumption of non-HDLs. We'll think of that as LDL. So as we move from left to right, we're consuming higher levels of LDL, and we can see that the risk of stroke increases. The filled boxes would be patients who had lower levels of HDL consumption, and the open circles, higher levels of HDL consumption. As we can see, lower levels of HDL consumption are associated with an increased risk in stroke. This is a little more obvious in the plot on the right. Here, HDL consumption is shown on the x-axis. Higher levels of HDLs translate to lower risk of stroke. Now the filled boxes represent higher levels of LDL consumption, which translates to an increased risk of stroke. And the open circles would be lower levels of LDL consumption. So by simply modifying what you eat, you can adjust your stroke risk factor. So obviously consuming foods that are lower in LDLs is going to translate to a lower risk factor of stroke, and consuming foods that have higher levels of HDLs will lower your risk factor. Now, fat does matter, especially body fat, because it's associated with other stroke risk factors and correlates to stroke risk. Here we can see insulin insensitivity in obese patients, leading to an impairment in insulin-dependent relaxation of blood vessels. That's what we're looking at here. The y-axis is showing us the degree of relaxation. In this case, higher values equate to greater relaxation of the blood vessel in response to a sub-nanomolar dose of insulin. There's certainly overlap between controls and obese patients, but as a group, obese patients have a reduced degree of relaxation of their vasculature following insulin stimulation. Another modifiable set of risk factors would be drug use. Smoking, regardless of what it is, increases stroke risk. The data on tobacco use is fairly clear. Cannabis use is a little more difficult because of the confound of tobacco use. People who smoke cannabis tend to also smoke cigarettes. And so it can be difficult to tease those two apart. Undoubtedly, if you're inhaling any smoke, regardless of what you've lit on fire, that's going to impair cardiovascular function and thus increase stroke risk. Alcohol use has a very clear relationship with stroke risk at higher doses. And so what we're looking at in either this table or this graph would be the relative risk of stroke based on alcohol intake per day. There's a little more information in the table that's going to tease apart potential sex differences. For example, if you look at the sort of middle of the table here, we can see as we move from left to right, where we're increasing our alcohol intake. Women don't appear to have any increased risk until they consume about 5 or more drinks per day. For men, it's about the same, but women have a much greater increased risk at 5 drinks per day. At the 1 or 2 drinks per day range, there may be a decreased risk of stroke, perhaps a 20% decrease risk, and this may have to do with the blood thinning effect of alcohol. So it's not as straightforward as any alcohol will increase the risk of stroke. It really has to do with the amount. So heavy drinking is undoubtedly associated with an increased risk of stroke, either ischemic or hemorrhagic. Cocaine and amphetamine use has a much clearer relationship. They increase stroke risk acutely due to their action as vasoconstrictors. So this is a pretty simple message. Don't smoke and don't do cocaine, and limit your alcohol consumption. So at this point, you might want to pause the video and make sure you can say something intelligent about all of these points here. Just very briefly, in the first point, what I hope that you recall is that low-density lipoprotein is prone to oxidation and can trigger an inflammatory response. Inflammation of the blood vessels is clearly a bad thing. For more on that, go back to Lecture 5. Atrial fibrillation, where we have abnormal heart rate, is a risk factor for stroke because there's improper clearance of blood, leading to potentially clot formation. And then when the clot clears from the heart, it can enter vasculature within the brain and cause embolic stroke. The last point here is really just something that you should think about because you will be dealing with stroke patients undoubtedly. As a physical therapist, PT is a very important part of recovery following stroke, and so you'll want to be able to have already have thought about how you'll talk to patients about these risk factors for stroke. I'm not going to tell you how to deal with patients or anything like that, so this is something that's up to you to figure out. As far as recovery and treatment of stroke, really it's all about restoring normal blood flow, reducing risk factors, and then promoting reorganization of the nervous system through rehab. In the short term, it's all about restoring blood flow. In the case of hemorrhage, if you can repair it surgically, that's fantastic. You won't be doing this, so this isn't something you need to worry about. Imaging is going to help distinguish between hemorrhage and ischemia. Some of the symptoms can also help distinguish between that, like a severe headache is suggestive of hemorrhage. If it's ischemic stroke and there's no sign of hemorrhage, then you'll want to break apart the clot. With TPA, you can also thin the blood. There's a variety of blood thinners. Aspirin is incredibly cheap, so it's often used. This needs to be done within 3 hours, ideally, maybe 4.5, but the sooner the better. You don't want to administer blood thinners to patients with hemorrhagic stroke until after the bleed has been controlled. And this is kind of controversial. The use of anticoagulants in the case of hemorrhage was historically advised against because of the association between aspirin use and hemorrhage. However, in large meta-analyses, the risk of this is about 0.2 per 1,000 patient years. In other words, over 5 years, if you follow 1,000 people, one of them will have a hemorrhage as a result of the aspirin use. So it's an incredibly low risk, but undoubtedly the use of blood thinners will decrease the risk of secondary ischemic stroke. Like everything in life, it's a cost-benefit analysis. You have to weigh the pros and cons of the use of blood thinners following a stroke. In the long term, you want to reduce risk factors by modifying your diet, the degree to which you exercise, smoking, alcohol use, etc. Blood thinners are, for the most part, going to be used to reduce the risk of secondary stroke. And then relevant to you all would be task-oriented physical therapy. In other words, if you want a patient to get better at a certain task, have them practice that task. Now, when we're thinking about functional recovery, this is going to really involve two things. First, there's just the restoration of blood flow that allows the neurons that were compromised but not yet killed to resume normal function. So you get this immediate recovery simply by restoring normal blood flow. Of course, the neurons that were lost will not be improved by restoring blood flow. So in order to compensate for the lost neurons, what we have to have is neuroplasticity, or the rewiring of our nervous system. So I'm going to do a little bit of a background here. I'm going to try to explain the concept of neuroplasticity. It's pretty straightforward here. You got to go through it a few times. So I don't know about you, but when I think about the world, I think about it as nothing more than patterns of neural activity. Everything that I know, see, feel, and do is nothing more than a pattern of activity in my nervous system. In other words, all information is stored as discrete patterns of neural activity. So if we look at this poor little rat here that's in an inhibitory avoidance conditioning study, in this case it's been put in the dark and an electrical shock has been delivered. So there's two things going on at the very least. There's a lot more than that, but we're thinking about two things here. There's the rat's perceptions, it's dark, and then there's whatever it's feeling, which would be pain. It's getting an electrical shock in its paws. So there's going to be two different patterns of activity that go on in its nervous system. And there's a concept called Hebbian plasticity, where we say that patterns of cells that fire together wire together. If you can remember that, that's a big part of neuroplasticity. Cells that fire together wire together. So let's see if we can walk through this diagram here. In the top, this is going to be memory formation. This is before Hebbian plasticity has taken place, so we want to think about two different networks. In our first network, that's sensing pain. So we got our red neuron that gets activated by the electrical shock. It communicates to the purple neuron that produces the feeling of fear. And then we have our gray neurons that are going to integrate information and create some conscious perception. All right, so I've simplified the rat's nervous system here to 6 cells. You're probably thinking this is an oversimplification, and you're correct. So pain activates the red neuron activates the purple neuron, and that creates the perception of fear by stimulating this downstream gray integration network. The rat is also aware that it's dark because there are visual neurons. In this case, there's a green dark sensing neuron. The rat's in the dark, so this neuron is active. It's going to communicate to some orange neuron that's going to encode information about context. This would be location. Where am I in space? What are the, in this case, light conditions? And then that orange neuron is going to communicate that I'm in the dark to that gray integration network. Now in that little box, what I'm highlighting would be a very weak connection between our context responsive neuron and our fear responsive neuron. you might not appreciate this, but there are what we call silent synapses in our nervous system. And these are exactly what they sound like. These are synapses that create no postsynaptic effect. So when that presynaptic neuron releases neurotransmitter, it creates no change in electrical activity in the postsynaptic neuron. This might seem like a waste, and it is until it's not. What it allows the nervous system to do is dramatically rewire itself without having to create new axons and form new synapses. It just simply turns on pre-existing synapses that were previously silent. Okay, so in the top we have co-activation of the pain sensing and dark sensing networks. And remember, cells that fire together wire together. So some of those silent synapses are going to get turned on, and we'll talk about how this takes place next year in greater detail. But neurons are able to sense when the pre and postsynaptic cells are active, and when that occurs, they strengthen their synapses. So in the bottom, now anytime it's dark, that dark sensing network is going to be sufficient to activate the fear responsive neurons and generate fear. So if we compare the top, in this case, the electrical shock was needed to create that fearful response. But in the bottom, once the rat has associated the dark condition with the shock, it now has the memory. And so now it becomes afraid because it's dark, rather than afraid because of the shock. If this doesn't make sense, come by and see me. But if you can remember cells that fire together, wire together, you've got it. And just think about how you learn people's names. This is not innate knowledge. When you look at their face, everyone has a slightly different face, so we get a slightly different pattern of activity in our nervous system in response to someone's face. When we hear their name, that creates another pattern. And so by repeatedly seeing someone's face and hearing or using their name, we start to link those networks together such that when we see their face, that's going to be sufficient to bring about their name. Or, for example, how are you going to study for this exam? You're probably going to review material multiple times. By reviewing material over and over, what you're doing is causing repetitive co-activation of different neural networks that encode whatever information you're reading about. And in doing so, you're going to solidify connections between them and thus create memories. Again, more on this next semester. Now, when we're thinking about neuroplasticity, it's not about forming new neurons, it's about modifying connections. I just want to make that point clear. In this panel, what we're looking at is the cortical mapping for digits 1, 2, 3, 4, and 5 in the owl monkey, before and after amputating digit 3. So on the top, panel A, we can see there's an orderly arrangement of cortical neurons that map to digit 1, then 2, then 3, then 4, then 5. So this is just essentially the surface of the cortex, and they're showing you which neurons are corresponding to which digit. When you cut off the third digit, those neurons don't die. They just modify which digit they map to. So now we see it goes from 1, 2, 4, and 5. There's not a big empty area of inactivity. Neurons are able to modify their connections. And so now, rather than mapping to digit 3, since that doesn't exist, they map to either digit 2 or 4, depending on their location in the cortex. In the case of stroke, it's not the loss of body part. Instead, it's the loss of neurons. And so what we have to do is rewire the patterns that we've created. And that typically involves 3 different stages. There's the cognitive stage, where we have a great deal of conscious effort required to carry out movements, and they are error prone, they are not smooth. The cognitive stage really is all about the cortex, trying to identify which patterns need to get linked together.
This kind of movement or
that. Okay. And where is that?
Squat. A squat with bad form. So she's not bending her knees. She's going to be prone to back pain as a result.
You're kind of bending like that.
Feedback is
Okay.
very important
What I
here.
want you to do is bend your knees and kind of poke your butt up a bit.
And so what she's trying to do,
Good. Now bend your
is
knees. Now stick your tailbone
link
up
up
towards the ceiling.
the cortical
I
networks
want to hollow this
that
part of your
allow her
back
to
and
bend
arch your belly
over
forward.
at
That's
the,
it.
at the
Okay.
hips,
Reach your arms out in
but
front
not
like you
at
were
the back,
before.
and also
Right.
bend at the knees. So this requires a great deal of thought. Here you can see some
Step
employ some
back
tools
this
to
way
give
a
her
little bit so we can see in the
external
mirror.
feedback.
Okay, can you see yourself in the mirror? Yeah. All right, so you've got this kind of nice little curve in your back. Bruce, do you mind just popping your feet down for me so we can just see them? That's it. All right, so now just watch your back and bend forward for me, like do your dishwasher emptying thing. See how that kind of all rounds there? Okay, what I want is that not to round. Okay, up you come again. So see how it's kind of rounded that way at the moment? Okay. Can you put one hand back and hold that bit that's on your bum? Okay, put the other hand over your shoulder and hold that bit that's up there. And can you feel that sponge thingy? I want you to not squash the sponge. Okay, and I want you to just practice bending forwards just a little bit, not to your full range. I want you to practice bend forwards without squashing the sponge. You're looking good. Yep. Good. And up you come. And just down and up a couple of times for me. Really trying to not push the sponge. Trying to leave the sponge fully expanded. Good. Okay, I'm going to take this.
So in this stage, what she's trying to do is link up the cortical patterns that allow her to not bend her lower back, but bend at the hips, bend at the knees. And by practicing this movement, of course, with feedback, what she's doing is co-activating those networks repeatedly and allowing Hebbian plasticity to work its magic. So that rather than having multiple discrete patterns, now it creates one unified pattern in the cortex. So the cortex has fewer things to think about. Rather than having to do 3 different things, it just simply has the thought of squat. This movement isn't going to be fluid and effortless until we create this pattern in subcortical structures, namely the cerebellum. So in the next stage, in the associative stage, here we can see an improvement in the movement. It's still not effortless and error-free yet, and it still requires some attention. So what we're doing now is transferring this new pattern that we've created in the cortex to subcortical structures. All right, well, let's watch this.
I'm just going to put about that much tape up your spine there. So, good, stand nice and tall. All right, so that's going to just serve to replace that stick, hopefully. So what I want you to do is just bend forward, and you'll notice if you bend that you stretch the tape. Okay, don't stretch the tape. Okay, so I want you to do that exact same thing that you did with your hand on your back before, but without the hand, and just don't stretch the tape. So it's exactly the same strategy as the stick, okay, in terms of what you need to do. Yeah?
Yeah.
Cool. Any pain at this time?
No.
Okay.
So here you can see that she executed the movement much better than in that cognitive stage. It still wasn't error-free and automatic yet. That's what we see in the autonomous stage. So for all the movements that you carry out in your life, you're probably in the autonomous stage unless you're learning a new skill, like playing the drums or something like that, where you're having to create new patterns. But things like walking, taking the steps, jumping, throwing a ball, we're all in the autonomous stage. We can do this without much thought, and we can multitask. We can walk and talk at the same time. because the motor programs that execute walking are for the most part carried out by subcortical structures. The cortex simply has to think walk rather than pick up right leg, move it forward, put it down, pick up left leg, right? We don't have multiple motor programs to think about. We just simply think stand up and walk. This is going to be executed automatically and smoothly by subcortical structures. So this is the general staging of motor learning. It's first very uncoordinated because we're involving the cortex. The cortex has essentially infinite possibilities, but very low coordination. The subcortical structures are going to work out the timing of different muscle groups to execute a movement in a fluid and coordinated manner. So only whenever we begin to include the subcortical structures in the motor program do we have fluid, error-free execution. So as you acquire a skill, it begins in the cortex. When we create that pattern, we transfer it to subcortical structures, and when it's solidified in both locations, then we've reached the autonomous stage. That is undoubtedly a vast oversimplification, but it's pretty useful. Okay, again, you might want to pause the video here and make sure you can say something semi-intelligent about all of these points. Briefly, short-term management is all about restoring normal blood flow. Long-term management is all about reducing risk factors and promoting functional recovery. You have about a 3-month window following stroke where you can expect to have the greatest improvement in function. So this is where physical therapy is key. The ways in which functional recovery occurs really would be short-term and long-term. Short-term, restore normal blood flow. And when you do that, the surviving neurons in the penumbra can resume normal function. So you get immediate recovery of function from those neurons that were simply impaired but not yet killed. Long-term functional recovery requires rewiring of the cortex and subcortical structures involved with motor function. So that would be the motor learning. The different stages of that, you can look in the last slide, but you have your cognitive, associative, and then autonomous. And that's involving the cortex for cognitive. We're bringing in subcortical structures in the associative stage, and in the autonomous stage, the patterns in the cortex and subcortical structures are strengthened so that we can execute movement fluidly. So first we work it out in the cortex, then we work it out in the subcortical structures. The last point here is something that really only you can answer. I'm not a physical therapist, and I will never tell you how to be a physical therapist. So my only advice here is when you're working with patients, just focus on what they have impairments in. Learning is incredibly specific. So if they have issues with their upper limbs, work with the upper limbs. If they have issues with the lower limbs, work with the lower limbs. What you do there is totally up to you. Okay, that's all I have for you for this lecture. The main points to get out of it would be the risk factors for stroke, and then understanding, first of all, what neuroplasticity is, what Hebbian plasticity is, and how these play a role in motor learning. Understanding that the initial stages of motor learning involve creating new patterns in the cortex. In the intermediate stage there, we then transfer those patterns to subcortical structures, and then at the autonomous stage, that's where we have solidified motor programs in cortical and subcortical structures to allow the fluid execution of movement. If you have any questions, shoot me an email or drop by my office. Otherwise, I'll see you Monday. Happy studying.